during this. A lot of this is focused on my interest, which is I'm a facial plastic trained surgeon. So I did my residency in Indiana in otolaryngology, and then I actually did a fellowship in facial plastic and reconstructive surgery at Johns Hopkins. And that was last year. Then I started my position here as assistant professor in September. So I'm just sort of building my practice now, and a fair amount of it has been, airway reconstruction, nasal reconstruction, and a lot of it, can be a mix of cosmetic and functional. But generally, here we have a ton of functional and large scale reconstruction for nasal airways. So I'm really excited. It's been busy for somebody new like me to start out. So, no disclosures. I think the only disclosure is I'm mostly focused on the nose. So my practice is a lot of nasal airway. I do, do some pharyngoplasty and tonsillectomy, but I'm not usually doing any tongue-based suspensions or any hyoid suspensions of that nature. So I'd like to focus more on the nasal airway. And so, this is kind of just some background stuff. Obviously, you guys know the OSA is a big problem. Sleep disordered breathing is a big problem. We're seeing, these numbers, every time I look at these numbers year by year, it's somehow getting bigger. And the prevalence is, of course, a little bit unknown, but assumed to be just increasing and creeping up every day, probably given to some degree from the obesity pandemic that we're experiencing as well. And, there's a ton of sequelae. We're trying to prevent all of this from happening. And we're just seeing, again, a higher frequency because we're I think, finding a little bit more undiagnosed sleep apnea in the population. And even those that are diagnosed are not compliant. So we're, struggling to treat these conditions or at least prevent them. And, this ranges for multiple reasons. People have sleep disordered breathing. I think the point here is you can get the snore without apnea and you can get the snore with apnea. And there's the whole continuum that's between those two. So really it's investigating where that level of obstruction is, where we need to be treated. And my focus tends to be on the nasal airway, the nasopharynx, things of that nature. And we see increased upper airway resistance from all of these levels, but especially from the nasal airway, given its high resistance in the breathing. And that leads to some snoring, upper airway resistance syndrome and obstructive sleep apnea, small range of things. And that kind of creates this whole, dynamic between sleep apnea and nasal symptoms, rhinitis, and nasal obstruction from craniofacial abnormalities and nasal deformities, septal deformities, valve deformities. And then you have on the other aspect, the nature of the human in terms of what their obesity status is, what their neck circumference is, and their pharyngeal kind of architecture. And add to that if they have fat deposits and things of that nature. So upper airway surgery is complicated. There's a huge range of options for upper airway surgery, and this is probably just the basic list that you'll see of options. And really, it's interesting because looking at this list, there's a lot of options, but my focus tends to be on the nasal airway. So looking at septoplasty, turbinate reduction, but also I wanted to add some things to that list in terms of things that I do very frequently for nasal airway that I feel really helps the nasal airway and decreases the nasal airway resistance for these patients. So, the question really is, are rhinologic treatments helpful in sleep disordered breathing? I think, there is definitely a role. And this is kind of looking at isolated nasal airway procedures. There's really not a definitive conclusion on all of this. There's a lot of contradicting papers, which I'll look at. And the success is just difficult. There's low predictability and just some high dissatisfaction among patients at times. So looking at the nose, this is what I love. I mean, this is what I look at every day. Patients come to me and they're talking about every little part of their nose that causes them some sort of problem. And it's really understanding this architecture that makes up the external nose and then leading into the internal nasal airway. So just understanding where we're starting from, you have the upper, the middle, and the lower third of the nose on the outside. So that's the bony pyramid on the upper third. The middle third and the lower third are comprised of soft tissue and cartilages. These tend to be paired bones, paired cartilages. So you have the paired nasal bones, you have the paired upper lateral cartilages, and you have the paired lower lateral cartilages or lower cartilages. And generally, the upper part is pretty much all bone. So that upper third, you can feel it. The middle third is pretty much cartilage. It's made up a majority of cartilage, the upper lateral cartilage, and then the soft tissue over it, providing structure there. And then the lower third tends to be partially cartilage, but partially soft tissue. And it's interesting about the soft tissue that makes up the lower third of the nose, because it's really not found anywhere else. It's this fibrofatty tissue that has inherent structure to it that you don't see anywhere else in the body. So interestingly, even though we have so much strength on the sides of our nose, or majority of us do, there's no cartilage there to support that. The cartilage tends to travel more superiorly, which you can see on the image here. So we're seeing that, the cartilage tends to travel superiorly, and then this fibrofatty soft tissue laterally doesn't really have cartilage. So in patients that it's a little bit weaker in that area, they tend to have malpositioned upper lateral cartilage. So lower lateral cartilage. So it tends to be higher. And then this part of their nose tends not to have a lot of cartilage support. And then they end up having collapse. And we'll discuss that a little bit further. There's accessory cartilages, little ones, the sesamoid cartilage, things of that nature, but not so important. And then you have the septum, which we'll look at here. So, septal anatomy, pretty straightforward, cartilage, bone. The anterior portion of the septum is made up of the cartilage. The posterior portion is made up of the bone. We really, when we do septoplasty, are just trying to remove any part of this cartilage that's deviated. The thing that makes my job fun is I get a lot of complex septal deviation, a lot of complex nasal deformity, and that tends to be where I see a lot of range of this kind of deflection of the septum that needs to be treated. So that's that's really my job, is to analyze these nasal airways in order to figure out exactly how they can benefit from potentially surgery. And a lot of times it's anatomical in nature, and medical treatment is usually not going to be optimal. So when I look at the nose and the nasal airway, I know that the resistance is high, right? We breathe through our nose, we breathe through our mouth, we can tell a difference right away. We breathe through our nose, there's resistance. We breathe through our mouth, not as much resistance. You wake up in the morning, you have congested nose, you're having a lot of resistance to breathing. You experience the nasal phenomenon of inferior turbinates swelling up on one side, then swelling up on the other side, and it tends to be difficult to breathe. So we know there's a lot of resistance there. And then we look at the two basically parts of the nose that tend to contribute to this resistance, and that's the external valve and the internal valve. So it's hard to depict exactly what these are when you're looking at the nose from the outside, but it's kind of nice. I can show you on video up close with my nose. But really the external valve is any part below the internal valve. So the internal valve is made up by, if you think about it, it's the lower part of the upper lateral cartilage. And so it's that caudal edge of the upper lateral cartilage that makes up the internal valve in the nose. And then anything underneath that going down into the external portion of those, or the nostrils, is the external valve. So there can be any combination of collapse or narrowing from all of these things. So when we look at the external nasal valve, it's comprised of the alar soft tissue, the lower lateral cartilage, the nasal sill, and the columella. So it's kind of from underneath, when you look at this border, it's the columella, that ala, the soft tissue, and then the sill of the nose here. But it actually extends all the way up into the upper part of that lower lateral cartilage. And then you're looking for, basically on exam, when you look from underneath, is there any sort of collapse of that cartilage as they breathe? The internal nasal valve is a little bit more difficult, in my opinion, for people to catch collapse because it's not as apparent. You pretty much have to try to inspect the inside of the nose to see how the upper lateral cartilages sit. And what you're looking for is actually a little bit more focused on the internal part of the nose. And so that tends to be one that you have to actually put in the instrument. And we'll go through that about how to test for collapse of the upper lateral cartilage, and what we call the caudal maneuver. So the borders of that tend to be the septum itself, similar to the columella as it was to the external nasal valve, but it's really an extension of the septum. And then we go to the lateral superior border, which is the caudal border of the upper lateral cartilage. So we see that here, where we see the upper lateral cartilage, and then the attachment to the piriform bone, which is where the nose kind of sits on the face, on the maxilla. And then you have the anterior head of the inferior turbinate. So when you're looking from underneath at the nose, you're really seeing this kind of triangle that exists from underneath. And that's also depicted here. And that triangle tends to have an angle of about 15 degrees. So that's really the goal. If you see a very tight angle there, that can be contributing to resistance or nasal airway obstruction. And then trying to lift that up to see if they have benefit is one way to test if there's valve obstruction or valve resistance. And then we know that, as that cross-sectional area decreases, we're going to have greater resistance to the nasal airflow. So it's really crucial, I think, to evaluate that. So, this is nothing new, the Bernoulli effect, and, the fact that if you increase that airflow, you try to increase that speed, you lower the pressure, you end up causing collapse. But that's not all. I mean, it's not always just dynamic collapse when you try to increase the velocity and decrease the pressure. There could be static collapse. So it could just be that their valves are narrow and they need some sort of expansion. We'll look a little bit at the some of the photos here. So, here we see static collapse. On this left side, we see basically somebody that's not actively breathing, but they have cartilage that's basically just blocking that part of their nose. And you really have to look for it. They're not gonna have the collapse on the outside. You have to be able to look up on the inside. And what you're seeing here is the lateral edge of that lower lateral cartilage. So really it's that edge of the lower lateral cartilage. Now, in this case, this is this depiction here is of a dynamic collapse, but the idea is there's a recurvature of that cartilage that's leading to that sort of static compression of the valve. And so those patients generally benefit a lot from a valve surgery or valve procedure. I'll talk a little bit later, but we're offering some in-office things now. So then we look at the dynamic collapse, and these are the more fun ones where you have the patient breathe in quickly and you can kind of see the nostril collapsing. And that tends to be the simple, kind of straightforward problem. And not all patients have, I can bring in my nostrils just like that, but it doesn't cause me a problem. So for me, it's not actually an issue with my resistance or obstruction, but in some people it can be. So here's what the evaluation looks like for most patients. So we have the caudal maneuver, which is basically just people say they lift the cheeks and they feel benefit in the valves area that helps them breathe better. And then we have the modified caudal maneuver, which is if you actually take a Q-tip or an instrument, and this it's a curette in this picture, and they actually go in and try to evaluate which cartilage, which part of the nose is causing the obstruction. And as a surgeon, that's what I tend to do because I'm guiding where I'm going to be repairing the valve or which location and which level I need to work. So we have a lot of different ways to evaluate the nose. Anterior rhinoscopy is probably the most common that we see in the clinic. And that's looking for anterior septal deflections, looking for the turbinates, which sit on the lateral walls, the inferior turbinates, and then looking for polyps that are more anterior. Nasal endoscopy tends to be where the ear, nose, and throat kind of takes over to look a little bit more posteriorly, look at the meatus of the sinuses to see if there's any sort of polyp disease there or signs of sinusitis. And then just looking for the back of the nasopharynx, generally if there's any adenoid hypertrophy or any sort of tumor that's causing some of the obstruction. And then CT scans, generally for me, not performed unless they're complaining of some sort of sinus disease or sinus pressure, and there's some sort of indication of it on the scope exam. So not always getting a CT scan, but it is definitely pursued in patients that have sinus issues.
To what degree does the internal valve fixed, or is it functional like your Alanase can decrease nasal resistance remarkably? And do muscles attach to the internal valve as well?
Yeah, there are some muscles. So the levator aliquot nasale does attach there, but it's not as active. So it's more of a tension, I think, in terms of the activity. So when you have you can actively dilate your nose, right? And you can see the ala dilate, but you can't really do that with the upper lateral cartilage. So it tends to be more of a static, just tension of the muscle that leads to that. What you'll see is patients with facial paralysis end up getting weakness of that, and then they get collapse of the upper lateral cartilage. But it's not really an active muscle, so it's not one that you can control. But it does create tension, like passive tension on the upper lat. So, but yeah.
Okay.
So, and that's one of the things we commonly treat. I actually, part of my practice is a lot of facial paralysis, and you see patients that have that kind of deviation of their nose to one side because they've lost all of that passive tension on that side. And so fascia suspensions can help recreate that, or just weakening the other side to bring symmetry back to the face. So, we look at treatments for this. We have reversible factors, we have non-reversible factors. Looking at rhinitis is the reasons there's probably three main ones that you'll see: allergic rhinitis, non-allergic rhinitis, and then rhinitis medicamentosa, which is the people that are addicted to Afrin and have refractory swelling after cessation. And then there's the rhinosinusitis patients that tend to have frequent sinus infections or chronic sinus infections. In those cases, we're trying medical therapy. We're trying to reverse whatever the causes their nasal obstruction. And then we have the non-reversible causes, which are the septal deviations and the valve collapse, which tend to be needing some sort of intervention. Non-allergic rhinitis is probably one of the more frustrating ones for patients because there's really no optimal treatment. A lot of times it's just kind of, we can provide some of the stuff for the postnasal drip, but it's really not easy to get cessation of symptoms. So this kind of gets into the more relationship of nasal obstruction to sleep disorder breathing. These are all the theories that are behind it. I don't have to focus. I talk about each one of these, but obviously if you guys are aware of these, I don't need to talk about each one. But the most common thing that we go through is the Starling resistor model, which is basically upstream resistance in the nose leads to downstream resistance collapse. We can see that when we try to breathe in very quickly, that tends to lead, when we have resistance in our nose, tends to lead to collapse of the airway. So it's very difficult when people have pharyngeal fullness and they're trying to gasp for air, breathing through their nose, they tend to create that collapse in the pharynx. Unstable oral breathing, which means basically people that can't breathe through their nose end up opening their mouth. Opening the mouth leads to retropharyngeal displacement, and you end up with some retroglossal collapse and tongue-based collapse that can, again, contribute to the nasal airway, the upper airway collapse. And then the nasal ventilatory reflex is a little bit more theoretical. There's some studies that show the effect of breathing through the nose being a sensation that then has a positive effect on arousal. It decreases arousal when you're able to breathe through the nose. When you're not, you tend to have arousals. And then it also decreases muscle tone if you can't breathe through the nose as well. So, and then there's also nitric oxide, which is produced in the sinuses in the nose and then travels into the lungs, which helps improve oxygenation and also muscle tension. So, this is the whole Starling resistor model. It's basically saying that Vmax is the flow of air, the velocity of air going through the pharynx, and it's really determined by the nasal pressure, nasal resistance, and the critical pharyngeal pressure. So these are the kind of focus when we're looking at improving nasal resistance. It tends to improve the pharyngeal critical pressure that then reduces the collapse of the airway. And I'll look a little bit more into this. So again, this is the pharyngeal critical pressure dependent on the nasal resistance, as shown by the Starling resistor model. So upper airway resistance with oral breathing. I mean, we know that this has been studied basically as people breathe through the mouth while they're sleeping and compared to as they breathe through the mouth while they're awake. So when people are awake and they breathe through the mouth versus the nose, there's really not much difference in terms of the upper airway resistance. But when people fall asleep, they lay flat, we start to see increased resistance from oral breathing versus the nasal breathing. And so a lot of that is thought to be related to just basically that displacement of the tongue, the posterior displacement. When you open your mouth, it leads to a decrease in the pharyngeal diameter, and then the base of tongue collapse that we get. Also, the palate tends to vibrate more, which ends up leading to some snoring as well. So all of that kind of contributes to the decreased muscle tone that ends up causing some pharyngeal collapse. So nasal ventilatory reflex is looking at, nasal airflow. It's suspected that, we sense the nasal airflow going through our nose. So studies have basically done anesthetize the nose, and they found that apnea increases when you anesthetize the nose in patients with sleep apnea. So if they're not breathing through the nose or not able to sense the airflow in their nose, they tend to have more apneic episodes. And then finally, nitric oxide. This has been shown to help with oxygenation. So patients that have limited supply of nitric oxide to the lungs potentially limit oxygenation. They increase oxidative stress, and they decrease the muscle tone. So all of these are kind of the four theories of nasal airway and contributions to pharyngeal collapse. So one study I thought was really interesting looked at nasal obstruction, and multiple studies have been kind of created based on this, but it looked at pulmonary artery hypertension in patients with septal deviations. So what they found was about 22 of the 51 patients that had septal deviations were tested. Actually, all of them were tested, but 22 of the 51 had pulmonary artery hypertension. And this was matched with a control group, which, they had a significant amount more of pulmonary artery hypertension. And what they found was after septal repair, there was a significant decrease in the pulmonary artery pressure. So, there is a relationship between just nasal breathing in terms of that sort of oxygenation and oxidative stress, I believe, on the pulmonary artery and just perfusion that can lead to hypertension. So it's definitely contributory in a way. Functional testing, I don't offer this, but we have rhinomanometry. I would like to get a device in order to test these further, just to have objective measures. And it's really not too expensive, so hopefully I'll be getting one in the future. But we're looking at just objective measures of nasal airway resistance that can be done by either manometry or acoustic rhinometry. And overall, these aren't what I look for in terms of how I decide whether a patient needs surgery. The better measure is physical examination, but also the patient's subjective symptoms. So if a patient is denying any sort of obstruction, I'm not going to be taking them for surgery, regardless of what I see in terms of their nose, because it's really a subjective measures, probably the best predictor of whether or not nasal obstruction can be relieved by surgery versus the objective measures here. And then we have multiple metrics.
Is that the sensation during wakefulness?
Yes, during wakefulness.
So if so that the sensation of nasal obstruction in breathing in wakefulness, you would then predict would give you more upper airway resistance during sleep.
That's what I would assume, but it's not. I don't think it's been shown.
It's been tested. No.
Yeah. So it'd be an interesting thing to look at in terms of the resistance awake versus asleep and the symptoms that they're describing with their nasal obstruction.
Yeah, and I've always been impressed. I did a lot of acoustic. I did acoustic, but it was well as rhinometry, and the mismatch between perception and nasal resistance before and after nasal surgery. I mean, that's why you guys sort of threw it out, because it didn't relate to perceptual improvement, which I think is really an odd mismatch as well.
Well, yeah, I mean, I'll tell you, I've seen many patients who I just don't understand how they don't perceive obstruction when I look in their nose, but I don't take them. But there are people I would wonder in patients that don't perceive obstruction that have sleep apnea, if there's a benefit in those cases to do something. Yeah.
Right. Decision making.
Yeah.
Yeah, I think or the sort of things you would do for something. Okay, sorry.
No, that's great. Thank you. So here's the goals of the treatment. The goals of nasal airway treatment are improving the patency of the nasal airway, obviously, reestablish physiological breathing, and minimize oral breathing. So you think it's simple, but I have to tell you, there's a lot of patients who I do nasal surgery on, and they don't breathe through their nose. I mean, they feel better. I tell them to breathe through their nose, but a lot of people don't have the perception. I think this is especially in children too. They don't perceive the ability to breathe through their nose until you tell them they can breathe through their nose. So there's almost a retraining that needs to happen in patients. And you could tell that during sleep, that may be even more difficult because the patients have been living with the nasal obstruction for so long that they really don't yet use their nose. So there has to be a learned mechanism to start using their breathing and nasal breathing effectively after surgery. So it seems simple, but there are those patients that need some retraining. And overall, I'm not going to go too much detail here, but allergic rhinitis contributes. There are definitely there's studies that look at sleep apnea during seasons of allergic rhinitis outside of non-allergic rhinitis seasons, and they found an increase in the AHI. This was a population of patients that didn't have sleep apnea, but they did find a significant increase in AHI with patients that have allergic rhinitis during the seasons of allergies. So it's definitely something to be investigating, in terms of the patients that have sleep apnea. And then we know that treating them with any sort of, nasal steroid or nasal antihistamine does end up benefiting their they're breathing subjectively, not so much objectively. So they don't really see a benefit. There was one study that showed a mild benefit, but it's just minimal. So the allergic rhinitis therapy overall, there's many options these days, really avoiding the allergens and traditional antihistamines. The non-sedating antihistamines are probably better in patients with sleep apnea, obviously. And then antihistamine nasal sprays are available. Corticosteroid nasal sprays are available. And then the anti-leukotrienes as well are kind of newer on the market. So there's allergy testing and immunotherapy as well. So definitely something to treat in patients with sleep disordered breathing. And then nasal dilators, they've been, again, it's kind of similar to allergic rhinitis. There's a lot on the market. It's a pretty big market, and they do increase the nasal valve. For the most part, they may help snoring, but really not going to help apnea for the most part in these patients. So surgery options, these are kind of the buzzwords: septoplasty, septorhinoplasty, nasal valve repair, turbinate reduction, endoscopic sinus surgery. And all of them are a little bit different. The only thing I'll tell you is septorhinoplasty and nasal valve repair get thrown around a lot. For the most part, if somebody's getting a septorhinoplasty for functional reasons, it's similar to a nasal valve repair. Rhinoplasty overall is the outside of the nose. Septoplasty is on the inside. So it's a combination of a septoplasty and a nasal valve repair that leads to a functional septorhinoplasty. So the septoplasty involves removing that cartilage inside the nose that's deviated and fixing that, and that's generally under general anesthesia. Turbinate reduction, there's multiple methods that we can do. They can be done in the clinic. They can be done with the patient in the OR at the same time as the other procedures. Generally, any nasal airway surgery, we're going to be doing turbinate reductions. And it's interesting, there was a drug-induced sleep endoscopy study that I found here that looked at turbinate reduction in 30 patients. So basically, they did a DICE, they did a turbinate reduction at the same time in all the patients, and they found a significant improvement in the sleepiness scale in all those patients. So, I think a turbinate reduction overall in these patients can be a benefit. And so it's, obviously if you're going to take them for something, it's worth potentially doing a turbinate reduction at the same time. It's really a low risk procedure. Septorhinoplasty and nasal valve repair. This is kind of the crux of what I was talking about with the valves. In this case, this is depicting the upper lateral cartilages getting a little graft here. So we take cartilage from the septum itself, we repurpose that to create more volume within the airway. So you can see you're going from that narrow valve here to a little bit more wide valve. Again, on both sides now, you see these grafts are placed, which ends up increasing the total amount of cross-sectional area and volume within the nasal valve. So overall, that's going to create a significant amount of increase in terms of the volume that air can pass through. And even that, as we know, that small area in the nose can be a substantial increase in terms of the, or decrease, I should say, in terms of the nasal resistance. So it's, it's kind of one of the go-to procedures that's done in terms of expanding the nasal airway that can be a big benefit. So these are other options for nasal valve surgery. So we can see support grafts that are placed for the ala. So this is a cartilage graft that's placed to support the ala. Here we see a strut graft placed along the side. And what this does is rests on the piriform aperture right on the outside here, so that it tends to be a cantilever effect. It prevents the nose from collapsing in that area. And they could be suited for whichever area has the most collapse. Patients can feel it on the outside, but generally it doesn't create a huge amount of width change on the outside of the nose, but it does help on the inside. These are some of the surgeries that we'll do. So, we'll take cartilage. This actually is cartilage from the ear because she had a previous septoplasty that was used then to place in the nasal valve, and it supports, it goes underneath the alar cartilages, the lower lateral cartilages, and prevents that from collapsing. Overall widening the airway. So this is a similar sort of surgery. We make a cut in the lower lateral cartilages, and then this cartilage graft is placed underneath it. This is just kind of a better view of that surgery, where you can, this is an open approach where they actually made an incision underneath the nose. And then this cartilage graft was placed and tucked under the cartilage in order to support it. So the outcomes of nasal surgery, you could probably make a meta, this is interesting, every 2-3 years there's a meta-analysis that comes out, and they probably add 1 or 2 studies each time. But for the most part, yeah, it seems like you can really hit the mark. If you do a meta-analysis, you'll get a publication out of it, and you just got to wait every 2 years. So the overall findings are, for the most part, improved quality. Sleep quality improves in nasal surgery, and these are all isolated nasal surgery, so nothing else was performed. And there's really not a significant decrease in AHI. One study, meta-analysis, did find a significant increase in the AHI, but it was just slight. So I think they were kind of grabbing at a few studies that had just come out in order to sort of improve that outcome a little bit. This is just the most recent meta-analysis that came out, and most studies for this surgery are not controlled. Most of them are septoplasty, so they're not looking at valve surgery as an option. It's rare to have the valve surgery offered here. I think it's because most sleep surgeons don't tend to get training in the valves. They tend to get more training in terms of the pharynx and the pharyngeal operations, and those people are doing the septoplasty as well. So the septoplasty tends to be more focused on where the septal deviations are. And it's actually very easy in these cases to miss valve collapse. So it's one of those things where if you're not looking for it, it's not there. But if you're looking for it, it can show up more frequently than you think. And it's a lot of ENTs miss it as well when they're doing surgery for the septum. So these studies tend to confirm that, like we talked about, improved quality of sleep, but failed to improve the objective metrics improve. And same thing here. So the sleepiness scale was significantly reduced in patients with OSA, and there was no significant improvement in the perioperative metrics. So I looked at these studies and I kind of took them, I did our own review here, and we were looking at a few things, but the nasal valve repair was the first thing. So really, there's only about 5 studies that mention anything about septorhinoplasty or nasal valve repair in their metric or in their data, and only about 3 of the 5 studies are focused on sleep, where they actually had objective metrics done for sleep. And so, interestingly, a lot of these studies don't really delineate between valve repairs and outcomes, which to me would be an interesting thing to look at. So really the only one that was isolated to valve surgery was this 3rd study here that was a prospective study that did look at sort of sleepiness scale and then objective metrics, and also I'm surprised they had funding for this, but got an MRI on every patient that had the valve surgery, and they showed increased nasal volume, which again is ridiculous to look at nasal volume, but they did that, and then they found an improved score, but they also found a significant decrease in AHI. So I thought that was interesting, and these were just isolated, isolated in nasal surgery, and I'll talk a little bit more, but improved CPAP tolerance is a known benefit from septoplasty or nasal valve or nasal airway surgery. This study down here, I thought was interesting because it looked at 92 septorhinoplasties. This actually came out, I think, in the last year or two. And this was from a facial plastics journal. And they looked at patients that had a septorhinoplasty, and they looked at a lot of functional outcomes, and the functional outcomes of sleep quality. The questionnaire showed improved snoring and improved sleep quality. So.
Dr. Rabbani, sorry, just a real quick question here. For CPAP intolerance, did any of these papers describe what type of CPAP intolerance, or for example, patients complain is pressure's too high, pressure's too low, or mass issues, what type of CPAP intolerance are they talking about?
They did both. A lot of them did both. Yeah. So I didn't go into too much detail about it. I did talk a little bit about CPAP intolerance, but the biggest thing is it reduced the pressures. So for the most part, there was a reduction in pressure, and then also just tolerance. People were tolerated for longer hours. So I don't know if they looked at, was the pressure decrease, correlated to the time that they tolerated it. So I'm not sure if they looked at patients with similar pressures, if they tolerated it for longer periods of time. I'd have to look in more detail at it, but they did find that people tolerated for longer, and then people also decreased the amount of pressure that they needed. So those were both benefits, but I'm not sure how they related to each other.
Got it. Thank you.
Yeah. So I think it.
Yeah.
Sorry.
Do you remember if they had some sort of threshold for pressure that they would do the surgery on, like over 12 or over 14, or was it any pressure?
I don't think that they used a threshold for the pressures. I think they just evaluated the CPAP tolerance as part of the study, but there was no threshold for it. These are some in-office nasal procedures we can do. So, if you have patients that you think, oh, well, they're too unhealthy, they potentially can't undergo any sort of valve surgery, it's not worth their time, or to see me or see any one of my partners. We do offer in-office procedures. One is the Latera implant. Obviously these are not going to be as strong in my mind as a surgeon as doing a cartilage graft. But what they do is, this implant actually travels right along the side of the nose here, and it does the same cantilever effect on the nasal bone rather than the piriform aperture. So it tries to support the lateral wall. And it's really just a Vicryl-based implant that absorbs over time. Whether it's truly effective long-term is, I have questions about it, but I still offer it to patients if they want to try it out. So definitely in the unhealthy patients that are consideration for valve repair or don't have a septal deviation, but just want a valve repair, this is an option. This is actually a newer device on the market that I have a heavier interest in, and it's a radio frequency device. So basically, it takes these cartilage and excess areas of resistance or narrowing, and then decreases them with radio frequency reduction. So there's really not been too many studies. There was one study I looked at that related the Vivera to sleep, and they did find there was an overall improvement in sleep quality. This study was pretty limited. It looked at like 3-month outcomes, so not really long, not too far along for follow-up. But I do think there's a role for these in-office procedures for the nasal valve. And this, we were talking about the CPAP tolerance, but this is just going through it's been proven that there's increased resistance and tends to be a non-acceptance of CPAP with higher nasal resistance. So this just kind of looks at the This looks at the flow versus the pressure in people with nasal resistance and without nasal resistance. And you tend to have a better flow in patients without resistance. So they showed that the nasal resistance was a predictive factor for non-acceptance of CPAP. So as it increased, it tend to have, and as AHI increased as well, there would tend to be decreased acceptance of CPAP. And then this was a study that came out, let's see, I think within the last 5 years or so, but this was patients with nasal surgery improving CPAP compliance after repair of the nasal obstruction. So, one of the interesting questions is, can we predict who these patients are that benefit from nasal surgery? I mean, we could do a septorhinoplasty or nasal valve repair on a lot of patients with sleep apnea, but even with obstruction, it may not benefit them from a pharyngeal morphology standpoint. So only a few studies have looked at pharyngeal morphology preoperatively and correlating it with benefits in nasal surgery postoperatively. And then even fewer studies, or not many studies, have looked at pharyngeal morphology before and then pharyngeal morphology afterwards. And so this is kind of a quick summary of that, but so there are 35 patients with apnea in this study, and they basically looked at the Mullen-Potty scores and the retroglossal space. These were done while the patients were awake, so they were looking at the Mullen-Potty while they were sitting up, and then supine, they had them lay down and looked at the retroglossal space. So it's not quite the same as doing a DICE, but they were looking at what in these patients were some predictive factors in the clinic that you could look for benefit from that. Like, can we tell them, oh, there's a chance that we could help with your sleep apnea? So these patients were, there were 35 patients. 8 of them, or all of them underwent nasal surgery. 8 of them actually were responders. So they actually had a greater than 50% decrease in their AHI. And what they found were predictive was the Mullen-Potty score, and then increased retroglossal space. They didn't really they had an equation in the paper that you could use, but it wasn't like a raw number that you could relate to the improvement. So it was like kind of a one of those abstract things that really doesn't translate too much in a objective way, but it's still something to maybe use in the future going, if you're planning some studies. So they found that those 2 were predictive of the improvement, and it was really just a high palate and then wider retroglossal space. So, some things that we can expect is that if they don't have as much tongue-based collapse and we're fixing the nasal resistance up high, that we're going to see less palatal obstruction and less palatal resonance from decreased nasal resistance, if that makes sense. So, you improve the nasal airway, you improve nasal resistance, and then you end up with a better support of the palate. And you don't worry so much about retroglossal collapse in patients that have a wider retroglossal space. And then, so this was something we reviewed here about the pharyngeal morphology affected after nasal surgery. So, these are patients that had some sort of analysis of the pharynx after, and there were really just, I'd say 3, but probably 2 that I could describe. The third one was a little bit convoluted with its analysis, but the 2 were actually studies done by DICE. So what they did was, in one, they actually did a nasal surgery at the time of DICE. So they did a directed nasal surgery. This was retrospective. So it's, so there's a selection bias here because, basically anybody that needed the nasal surgery at the time of the DICE underwent the nasal surgery. It's not like everybody that had DICE underwent nasal surgery. So what they found was there was really no benefit in obstruction, like overall obstruction. And there was no significant decrease. There was a slight decrease in AHI, but there was an improvement in the sleepiness scale. So overall quality of life improvement. What they saw was that, I'm a little blocked here, sorry, one second. What they saw was that the patients without tongue obstruction, so very similar to what we were talking about before, were found to have improved palatal collapse. So basically, if there's some way we can prove that the tongue base is not as much of an issue, then nasal surgery may be a big benefit for these patients in terms of the palate. And then the question becomes, who do we repeat a DICE on? So, who do we need to repeat a DICE on all these nasal surgery patients? For the most part, this is saying no. Most of these patients, the collapse is persistent because for the most part, isolated palatal collapse is not as common as tongue base and retropharyngeal and hypopharyngeal collapse. So for the most part, these patients don't need a repeat DICE, but there could be an isolated set of patients where you can identify that a nasal surgery alone may provide a large benefit. And then there was actually very recent study that came out in the past year that looked at similar set of patients, and they found that basically as they had a septoplasty and turbinate reduction, there was an improved, again, sleepiness scale, improved AHI, again, non-significant improvement in the AHI. But there was actually a decrease in the obstruction, the multi-level obstruction after nasal surgery, and the overall, the hypopharyngeal collapse was improved. And I wasn't really able to explain this one as well because that's really not where we see as much. But in theory, what we're talking about with decreased nasal resistance is that you would expect, improved critical pharyngeal pressures, and then that you would see less collapse of the hypopharynx. So this does go along with that sort of theory of the Sterling resistor model that there would be decreased collapse there, but not so much with the previous study that I mentioned in 2012. And then the last study was a little bit more difficult to, if you read it, it's 3 patients that underwent some sort of flow analysis of their pharynx with CT scan that I found to be a little bit convoluted and not really provide any useful clinical data. So, and the question is really how to go forward with this. For the most part, simple snorer, no apnea, nasal problems. I think the first line is a consideration to do nasal surgery. There generally tends to be a more palatal issue in these patients. There tends to be a resonant palatal issue, and there could be the need for small palatal surgery at the same time, but that could be probably predicted more based on their Mullen-Potty and how they look if they don't have any apnea. In those cases, I think nasal surgery, maybe a nasal valve surgery as well at the same time, could be a benefit. If they fail that, or if there's no evidence of a blockage or nasal collapse, then potentially a sleep endoscopy to evaluate the snoring could be of benefit. So in the obstructive sleep apnea of the patient, this was an interesting kind of stepwise way to treat these people. For the most part, I'm looking at patients that have some sort of anatomic blockage that's causing their nasal obstruction. And I'd actually be interested to see, is there a consideration, where is the the patient that we can jump ahead. And so, if they have an anatomic blockage and they have sleep apnea, the question is, should we be offering something? And I think that's exactly what we were asking before. Is there a way to look at some sort of objective measure of their related to their anatomic obstruction, whether or not there's subjective nasal blockage? And the question is, if there's subjective nasal blockage, should they be getting surgery anyways? Because we know that there's improvements in terms of the CPAP pressures, and then potentially a little small reduction in HI, but also definitely an improvement in sleep quality. So, I think it's warranted in a lot of these patients to have surgery for the nasal airway and potentially for nasal valves as well, septoplasty and valve surgery if needed. So really my final thoughts on this, I think there is a heavy role for nasal surgery in sleep disordered breathing. We know that it improves quality of life. We know it improves sleep quality. It tends to improve CPAP tolerance, may improve snoring, but there's not a guarantee in a lot of patients. And it does not predictably reduce OSA by objective measures like AHI. But one of the biggest things I have to mention is just don't miss valve collapse. It's one of those things where I think it's really in a patient with sleep apnea, it could be a very big benefit to fix that. And really nasal valve repair, we haven't extensively studied it independent of other nasal surgery. So there may be a bigger role than we know. And then looking at pharyngeal morphology, I think there's a role again to find how to predict who's going to benefit from nasal surgery. As I mentioned before, the high arch palate, the wider retroglossal space seems to improve those outcomes, but these are all while the patient's awake. So we may have to look at ways to evaluate that while they're asleep, the pharyngeal morphology before and after. And then does the nasal surgery change the morphology afterwards? So again, these are kind of before and after looking at these morphologies that we really have not been studied. So I think there's a big role for those changes before and after, especially in patients that objectively, subjectively, potentially objectively on examination, also from nasal resistance analysis may benefit from these surgeries up front. That's all I have.